From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy featured in the medical news section of JAMA.
I'm Rita Rubin, lead senior staff writer for JAMA Medical News. Today we're joined by Dr. Nancy Berlinger, a senior research scholar at the Hastings Center. Her research focuses on ethical and social challenges arising from population aging. Of course, one condition that is of special concern in aging societies is dementia, the collective term for Alzheimer's disease and related dementias. We're going to be discussing some of the essays in Living with Dementia, Learning from Cultural Narratives in Aging Societies, a new Hastings Center report that Nancy edited. Welcome.
Thank you, Rita. I'm delighted to be here.
Great to have you. Could you tell us about the genesis of this report?
Sure. This report was funded by a collaborative research grant from the National Endowment for the Humanities, and we had begun a conversation with them about this topic, about dementia, because we have a research portfolio here at the Hastings Center called Bioethics for Aging Societies. The idea of how could bioethics be for our whole society, not just for individual topics like research ethics or medical decision-making. Erin Lamb, who's a professor of medical humanities at Case Western Reserve University School of Medicine, co-led this project with me. And we succeeded in getting funding several years ago. We were thinking very broadly about this issue of the stories we tell about dementia, not just thinking about the individual story that a person might tell about having dementia or about caring for a person, but the social stories, the cultural stories we tell, including within the culture of medicine.
And I know, this is part of the title of your report. How would you describe narrative medicine?
Well, narrative medicine is an approach pioneered by Rita Sharon at Columbia University and now used widely in medical education throughout the United States. That premise is based on the idea that stories matter. The patient's stories matter, the caregiver's stories matter, and the clinician's process of responding to these stories matter, that we live inside of our stories. We sometimes say that stories are sticky. You remember them. You may see the graph or the pie chart, but you remember the story more readily. That was Rita's insight. And, she's done amazing work at that intersection of bioethics and narrative. What we wanted to attend to here was this larger dimension of the stories that are told in a society or a social group. Now, this is a newer thing to do. It's more associated with sociology or anthropology than it might be with narrative medicine. But we felt in an aging society like the United States, it was important for clinicians and for medical students and medical educators and many, many other people to think about what are the collective stories our society tells about a condition that is associated with population aging. Very likely a condition that anyone treating adults in the United States is going to encounter at some point or another.
In their training, most physicians do learn about the importance of eliciting stories from their patients. But patients with advanced dementia have lost much of their ability to communicate verbally. How can physicians draw out their narratives, their needs, and their wishes instead of relying only on what their caregivers have to say?
That's a challenge with respect to how we think about dementia. I think in addition to the challenges of communicating when a person has advanced dementia, there would be just the fact of when you have that diagnosis, there could be an assumption that what you say is not reliable, that you are a person whose memories are not reliable. And also you may be prone to behaviors that are seen as not standard, even if that is not your situation as a person with, say, early stage disease. And so part of it is making sure that clinicians, medical educators, trainees know that all of dementia is not advanced dementia, where a person has significant care needs and may have significant memory loss. but also to understand insights from fields like social gerontology about how people with dementia do communicate about their lives. Maybe there's word substitution. Maybe they use a different metaphor. But it doesn't mean that it is impossible to learn from people with dementia about their lives. And of course, medical educators will tell you that some of the most powerful, effective forms of medical education are when patients and families are present and talking about their own experiences. So that's one thing that might be an addition to, rather than saying, I'm going to look at a journal article or a published work and find stories by this patient population, I'm going to invite people with this condition into a grand rounds so that they can talk about what it's like to live with this condition.
And I thought it was interesting the mention that even people who are, in the advanced stages of dementia and who really pretty much have lost their ability to communicate with words, that gestures and other nonverbal ways of communicating shouldn't be ignored, that that's another way to gain insight into the person.
Absolutely. There's an essay I particularly like by a Canadian social scientist, Julia Henderson, who actually started as an occupational therapist. And one of the things she's talking about is arts-based approaches. We say, I wish everybody could have this. When we read about these amazing opportunities for people with dementia to be part of arts activities, for example, or theater activities, the work of Anne Basting is especially revered in this area. Underneath all of bioethics for aging societies is what makes a good life in later life. And in this collection, we're saying, well, what makes a good life even if you have dementia? And what would support a good life? So it's not always about what is a person's testimony or what is their decision. A person may not be able to make a medical decision, but life is more than medical decisions. And a lot of dementia care is much more than medical decisions. But it's about what is your life like, even with a very, very challenging condition.
I couldn't help but think of my father-in-law who died at age 100 and probably had been dealing with dementia since his late 80s. I still remember very much toward the end of his life, he always loved music and he loved, some of the big band music, and his grandchildren would play that for him. And he would get up and dance with them. And it just really touched something in this man who really had led a remarkable life.
That's a fabulous example because long-term memory in a person with dementia may be intact, and music is very powerful. And people tend to have a huge store of music, of lyrics that they remember from their teens and their 20s. You just get it. You're listening to music more at those ages. So that is very frequently part of really interesting community-based programs for people with dementia involving music. But there are also some really interesting approaches that involve, say, theater, for example. It's also used in Parkinson's, movement therapy. But part of it is because this is what people with dementia have said they're interested in. There's a little story we have in one of the essays where Mary Grace Becker, who's a great innovator in dementia programs, she's at the University of Washington, Seattle. She was leading a support group one day, sort of a conventional support group. And one man on the support group said, I've heard that improv theater could be helpful for people like us because we have difficulty maybe getting our words out. Do you think there's any sort of way we could learn that? And she'd never thought of this before. And she looked across the street and there was a theater company. And she said, well, nothing ventured, nothing gained. And she walked across the street and asked the executive director, look, we've gotten this suggestion from a person in our group. Does this sound crazy or what? And she said, I'm willing to try. And she named a family member who had dementia. So now there are improv theater classes for people with dementia in the Seattle area.
In your essay, you mentioned a video produced last year by the UK's Alzheimer's Society that really hammered home the metaphor of dementia as death. And you also point out that that metaphor is related to another metaphor, loss of memory as loss of self. So how might this kind of stigmatizing people with dementia as the walking dead affect their medical care and the quality of their lives?
You've really gotten to the heart of it right here, because when I came across that public service announcement from the Alzheimer's Society, which is a very respected institution that's sort of akin to the Alzheimer's Association, they release a big public service message every year so that everyone in the UK is going to, get the word. And this was very striking because the actor Colin Firth, who everyone loves and has a beautiful voice, was the narrator. So it was very distinctive. And there was some coverage of this in the press in the UK because it was very high production values, and it showed a youngish man, maybe 40, talking about his mother, eulogizing his mother. But he talked about all the times Mum died. And it was like 5 times before she biologically died. And it was all like, well, the time she forgot how to make the Sunday roast and the time she couldn't get dressed in her favorite outfit. I'm like, wow, this is a pretty tall bar. If like you forget a recipe, a lot of us would be dead, or like nobody else knew the recipe. And then the message at the end was, people with dementia die many times before their death. That is the perfect definition of what we're talking about. Nobody had to explain this death metaphor. It was understood. Oh, yes, if you forget things, you're dead because you don't remember other people or things that are important to other people, and then you're dead. And that's where Jason Karlawish, who is the director of the Memory Center at Penn, he's written very eloquently about this problem. When you talk about a group of people as zombies, yes, it is going to affect how you treat them. No one wants dementia. Nothing about this report suggests, oh, no, this is really fine. But it is a very heavily stigmatized condition. But Jason and others, and we hope we're doing the same thing, are making a point about ethics, about society, about how we should treat people. We shouldn't say that some group of people are beyond the pale. We should instead say that suffering shouldn't be stigmatized, and that these are people who are some of the longest standing members of our society. How do we avoid excluding people at the moment when we should be including them?
The point was raised in your report about how, wow, someone is just diagnosed and they're dealing with that. Far from the end of their lives or far from the end of their journey or whatever you want to call it, through dementia. But how that just can really affect someone who just received their diagnosis and is still like pretty highly functioning.
So imagine if you're saying, whatever I want to do, I want to make sure nobody knows about this dementia, because people could try to get me out of my housing, for example, or they'll just treat me differently. My father had Lewy body disease, and my mother was his caregiver. They would go to their congregation. This is before the pandemic, every week. And it's a congregation where coffee hour was a big thing. And she said, because of the Parkinsonian symptoms, your father couldn't walk very well. He would rely on other people to come up to him, and people knew he was ill with something. But when it became known that it was dementia, people stopped coming up to talk to him. They had come up the previous week, but now the stigma was there. It was presumed that you couldn't have a conversation, which not only affected his life, she said, it affected my life because this was the one time I got a break, And so it would have been really helpful if people were chatting with him so that I could go have a conversation with somebody else.
As someone who's written several stories about the new anti-amyloid therapies for Alzheimer's disease, I found the essay about the quest for a cure particularly interesting. What are the drawbacks of framing dementia as a medical problem?
Well, I think the drawbacks are framing it solely as a medical problem. We have a disease or a collection of diseases. It's a bit like cancer in that way, but one form is not the same as another. But if we are saying that the thing you do with respect to a disease is you look for a cure for that disease, well, yes, that's understandable. That can change your life. It has certainly transformed the picture with respect to certain forms of cancer. However, there are 7 million people living with symptoms of dementia in the United States alone. And if you know that these new drugs may tend to benefit people at a very early stage who have access to the treatment and the ability to withstand treatments that involve infusions, that involve scans, there's an awful lot of people in your patient population who will not benefit from those treatments in this generation, maybe the next generation. What are you going to do for them? I think we get into problems when we say medical and non-medical, like the non-medical isn't that important. The non-medical is where we live most of our lives. And so it is very important. And I think that essay by Peter Whitehouse and colleagues, and also Jesse Ballinger's piece on the history of dementia, are saying we have to think about how we're responding to suffering. How are we helping people to manage the suffering associated with the condition and live as good a life as possible? And if we miss that and say it's all pegged on a treatment, we're going to miss not only millions of people, but we're also kind of writing off the group of people who are too late to benefit from that. They're too advanced in their trajectory. We have to do better. Jason Karlowicz makes a point about this too. He said, we've got the biomedical approach, which is very organized and going toward treatments and clinical trials and pilots and so on. And we have this sort of very fragmented approach to social innovation, which is mostly at the community level. People have never heard of really great programs, in part because this is such a large country. So there might be something great going on in one place that people in the next state don't know about. And it's harder to share that community level innovation that's going on. And we discount it because often the people involved aren't MDs. It's not as scientific. It's very hard to measure something where people are having a better day, a better life. How do we change our culture? How do we change our stories? We can't just keep referring to people as not there or gone. We will devalue them if we talk about them that way.
Another point that Looking for a Cure brought up was looking at dementia through the lens of public health. And I don't think people typically think of dementia as a public health issue. But recent Alzheimer's Association International Conference last year, there was research presented about how the terrible forest fires that we've been experiencing in North America, how that might be linked to an increased risk of dementia. And the authors of this essay pointed out that dementia rates over the past decade have actually been falling in the U.S. and a handful of other Western countries, even though no cures have been discovered. Why is that? What have been some of the public health contributions to the falling rates of dementia? And maybe we need to think more about that perspective.
I'm so glad you brought that up. It's so complicated because the numbers are going to rise, even though the cases will fall. It has a lot to do with social changes like fewer people smoking. So you have this huge baby boomer generation that is of a certain age. It's just such a huge cohort that, yes, you're going to have lots and lots of cases of dementia developing. But there is a thought now that it's not going to keep going up and up and up forever because precursor conditions have been identified. So if you can prevent pulmonary disease, cardiac disease, diabetes, those sort of chronic conditions earlier in life, it will reduce dementia risk. Not in every case, but there are these environmental factors. I would also mention that we know that the risk of dementia doubles if you're Black than if you're white. It's also higher if you're Latino. And researchers I know who are studying this are looking at very early in life environmental factors to see whether or not these can have measurable effects. Do these lead people to develop the kinds of conditions that then become precursor conditions?
Nancy, I've really enjoyed talking with you. Is there anything that you'd like to add?
One thing I'd like to mention, other than reading the report and enjoying it, it's all open access, is also the work of Barak Gaster, who is a primary care physician who is at University of Washington, Seattle. He and his colleagues have created a toolkit that is called Cognition in Primary Care. And it's designed to connect the typical doctor, the PCP, with their population. Most people with dementia are not cared for in memory clinics. They're cared for by primary care physicians or nurse practitioners. And so it's very, very important for those practitioners to feel confident in caring for people with dementia. It offers a lot of very common sense tools like evaluating for hearing loss, because hearing is such a huge part of cognition. You might think that a person's memory loss is greater than it is because they just are not able to communicate because of hearing loss. but they also do coaching with primary care physicians. So remember that this isn't just a story about making decisions in the ICU, for example, or the end of life, but it's also about these everyday interactions in clinics that could make the quality of life for a person with dementia or for a caregiver better.
I'm Rita Rubin of JAMA Medical News, and I've been speaking with Dr. Nancy Berlinger, a senior scholar at the Hastings Center, about a new report she edited titled Living with Dementia, Learning from Cultural Narratives in Aging Societies. You can find a link to the report in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.